Yes. So this is going to be a debate between me and Dr. Mahendra, but really we don't like to debate. So I think it'll be more a discussion on viewpoints. So from this audience, which I'm hoping is more a medical audience, if you had to treat your patient and you were thinking of reversing his diabetes, improving his diabetes, can I have a show of hands as to how many would go with bariatric surgery? So can I have a show of hands with how many want to go with bariatric surgery? Let me count. I have 4 hands in the 5, okay? And whoever wants to reverse their diabetes, no? And can I also have a show of hands now for everybody else who wants to put the people on lifestyle changes, medications, Okay, so Mahendra, please look around the room over here. So now your job is to convert all of these people. So in a debate, how we do it is we'll re-vote at the end of this and we'll see if you can convert them all to surgery. Our drinks are on you tonight, right? I mean, this is Ahmedabad, so we're talking about coffee and tea, okay? So thank you all for being here, and we are between you and the end of the day. So I thought we'll keep it a little bit interesting and exciting. And you can just give me 7 minutes because the entire session is 15 minutes. So remission of diabetes was the topic. GLP or GIP versus metabolic surgery. So that's what we're going to talk about. And of course, I have a huge interest in this. So I thought I'll keep it very simple. I have no financial disclosure for this. And we'll say, why do we need to do remission? Why? Kyun magar, And what do you need to do? How much weight loss is needed for that? The main question is why bariatric surgery? Because how much weight loss do you really want to achieve? Does everybody have to look like all these movie stars that Dr. Shashank Shah was showing us? All of us don't want to lose so much weight. What are we trying to achieve is the question, right? So how will you go about it? That is the main crux of the matter. Whom are you going to talk to this and why not? Why not bariatric surgery and why not medications alone for remission of diabetes? So I thought I will divide my topic accordingly. For the audience to know, the ADA came up with a guideline and we have different guidelines. So it depends on the study you are looking at. Diabetes remission is defined as the ability that you bring down your HbA1c below 6.5%. And then you keep it at least for 3 months after you have stopped all glucose lowering therapy. So let's kind of at least know there is some target. Some of the studies like the original Stampede also looked at less than 6%. So it depends on what data you're looking at. We all know that weight gain or obesity is the main driver of type 2 diabetes. Not only urban but rural India is also getting affected. And we all know India is now facing the twin epidemic and a future pandemic that is coming in the children and adolescents, as our first speaker showed us today. Now, why and where did all this start from? Why did we think about remission? Because we were starting to get this data from bariatric surgery. That whenever they did the surgery versus medical therapy, not only did weight go down, what did they see? Lo and behold, the diabetes went away, of course, right? How much was the weight loss that they saw in the Stampede study? It was about 20%, 21.6 to 22% for bringing down the HbA1c below 6.5. So that is what I thought. I'll pick the key findings in all these studies. So we will discuss this now. Then how much weight are we trying to lose? So here is Stampede, HbA1c less than 6% or 6.5%. Of course, it did very well versus medications at the end of 5 years. And certainly this is the crux of the matter, is for how long can you stay and keep in sustained remission. So now let's go along. I just showed you the 21.6% weight loss is how much weight loss. Along came the direct trial, done by primary care physicians, done by nurses, practitioners, very simple, a simple diet which was given. And what was the weight that was lost? It was about 15 kilograms of weight that predicted almost an 87% remission in these patients. And we know that at 4 or 5 years, certainly we started seeing that the patients who regained the weight, they will also go ahead and get their diabetes back, but not to the extent when they first started. So those are keywords. What are you trying to achieve? Let's be realistic. When we see our patients, we need to have target setting, goal setting, which is realistic. We are not trying to achieve something that is supernatural. So what was groundbreaking to me about the direct trial is the beta cells ability. Isn't this amazing, guys? Don't you think? You've had diabetes for 10 years, 20 years. So this is where I'm going to bring you how do you select your patient as to what is the duration of diabetes and can our beta cells actually reverse and can we do it just with surgery or lifestyle measures alone? So direct trial showed for the first time, because it was a properly studied trial, that the beta cell could recover What they also was very groundbreaking about this was done under real life conditions and done by routine staff and not specialists like me or Akshay or anybody else in the audience here. And it was the first study to set remission of type 2 diabetes as a primary outcome. So these are things. Another thing is when you start looking at statistical analysis, this is very important to me, that the sample size exceeded the need for statistical power and the remission rate of 46% was much higher than predicted for any other medical trial. So this is something also to keep in mind. So you've been asking this question, sir, what works each time we need to ask, not just for intermittent fasting, not for ketogenic diet, for macronutrient, brown adipose tissue activation. What works? Is it the weight loss or is it something about the intervention? Because trust me, as Akshay said, the fat cell is beyond us all. There are so many hormones I can't even remember or begin to learn. And I tell my students that barochronology is going to be the new endocrinology, and that's what you need to learn beyond the 6 pituitary hormones. So we also know from various dietary interventions and type 2 diabetes remission studies, what matters when you're selecting your patients is the duration of diabetes. And if you look across this, if you look at the bottom here, we saw the best remission about 87. So if you look to the right of your slide, with the Stephen and Lim studies, but very small number of patients, 2911, very intensive trial. Again, the weight loss achieved was 14 to 15%. So couple of things that will predict your remission is the type 2 diabetes, the age of the patient, the number of years, if you get more aggressive C-peptide levels, but also the amount of weight loss. So this is where I talk about the treatment gap in obesity, that lifestyle modification alone will not do it with current pharmacotherapy. And then so what can we offer our patients between what we have and surgery? So this is where my topic is, will the emerging dual and triple incretin therapies improve on these patients with type 2 diabetes? And we now know that they can range all the way. We can see the weight loss goes to 20%, 25%, and we can be somewhere in between and not get into excessive weight loss. Because we know at 21.6%, even in the surgical studies, you can start to look at improvements in diabetes. For those who don't know, GIP and GLP-1 agonists are hormones that are secreted from the gut and hence known as incretins. The GIP hormone is way stronger than the GLP-1 hormone because beyond working at the level of the pancreas, the stomach, and the CNS, it works at the level of the adipose tissue. So please keep this one thing in mind when you start thinking about GIP. We know across the board that all the GLP-1 agonists reduce weight and therefore also bring down the HbA1c. What I want to show you is that when you start looking at weight loss with Wegovy or injectable semaglutide, we have data looking at 4 years, 5 years, in some cases even longer, that this weight loss which comes down stays down as long as the medication is continued. But we also know that most of the patients with diabetes or pre-diabetes, they will start to get out of this and get out of other medications. So yes, you can see that happening. Why is it happening? Is it simply the weight loss? Just like bariatric surgery, what you see is that the improvement in diabetes, the improvement in outcomes happens way sooner than the weight loss happens. The diabetes reversal starts to happen sooner than all of the weight loss has happened. Let me be clear. So therefore, we know that this is because, let me just go, sorry, to this slide over here, that these molecules improved beta cell function. So a subgroup of the patients with tirzepatide and semaglutide versus placebo, we found that the first phase insulin secretion improves as well as the second phase insulin secretion improved. We also know that when we started looking with a hyperinsulinemic euglycemic clamp, the insulin sensitivity improved, and this is calculated by something known as the M value or the glucose infusion rate. So tirzepatide and semaglutide improved beta cell function as well as insulin resistance at the level of the skeletal muscle. Now across the board we have several molecules in the pipeline, and as you can see with the newer molecules we will have to the level of 25% weight loss achievable. So you need to decide what do you want to achieve for your patients, to what is the level, what are you trying to achieve, and go from there. So a paradigm shift in the management in the diabetes is a need of the hour. We are moving away from glucocentric management to a vascular glucocentric approach. We are also in the remission eras. Now let me just be the devil's advocate and say bariatric surgery is not devoid of complications. There are several complications, acute complications. Of course, no surgery is free of that. What we, however, know is that return from these is not easily possible. The surgeon may try to convince you that he's going to reverse the surgery and so on and so forth, but please, put your hat on of your clinician and make sure. So we also have this nice outcome from JAMA paper that talks about certain risks such as fractures and cancers and suicide attempts which were higher in the surgical versus the medical arm. So here is Mahendra with his razor trying to, cut open your patient. And what I'm trying to say is that keep in mind, yes, medications are not going to bring down your weight as much as bariatric surgery. But at the time of type 2 diabetes, you've already lost half of your beta cell function. We have now newer GLP-1 medications which are becoming more and more affordable and available to us. In the dual triple agonists, we have promising data for preserving beta cell function. What we don't know, of course, I want to be sure, is that we don't know after stopping the medications. Is it again the weight loss, or what we have done to the fat cell? What have we done to the underlying pathophysiology? Losing liver fat, losing pancreatic fat in the direct trial were shown to be the key predictors who reverse the diabetes. So we don't know about the sustainability of the diabetes remission. However, when you're thinking of your patients, let's be reasonable. What are you going to offer them? Thank you very much for your attention.
Thank you, Rucha, for first of all having a biased opinion at the beginning of your talk. That was not required. Actually, at the end of talk, you should ask your opinion. So let us have discussion. And most of the time, you talked about weight loss, and less of the GIP and GLP-1 agonist. So that is another observation from my side. And if you look at your presentation, it means that with new or more effective weight loss medications, the metabolic surgery will be abolished, which is not true. In fact, I'm saying that it will be increased in future. Why I said so? Because I searched the same topic on Google AI and same question whether bariatric surgery will be stopped in near future so that I can change my field. The Google said, AI said, no, you should stay in your market and work on it and your numbers will increase. And that is what I'm looking at in future. There's more and more bariatric surgeries will happen because after this is a statement from ASMBS, that is American Society for Metabolic Bariatric Surgery, and we say that bariatric surgery is more effective and durable than the new anti-obesity medications and lifestyle interventions, and it is their position statement, not my opinion. There was a lecture on the same topic in ESD, that is European Association for Study for Diabetes, last, I think September 10th of last year, that more than almost 6 months back, in their annual meeting, where two experts, the one was metabolic physician and second was a metabolic surgeon. So L.J. Aron was from Well-Called Medicine, New York, who proposed medicine will replace bariatric surgery, while Francisco Rubino from King's College London, he said that bariatric surgery cannot be replaced by these anti-obesity medications. And why Aaron said this? Because the trend could be to treat obesity when it is going out of hand, means you start early and you can control it. That is true. The treatment might start in people with body mass index of 27 plus, when the target of BMI is only 25 for Americans, but we need 23 BMI. So only target is 10% of BMI change. If someone does not respond to one drug, there is always availability of other drugs which are coming in market, which you will also see. At the same time, the people who will be referred for bariatric surgery is possibly after they have not responded to medical treatment. That is happens with every medical treatment, including diabetes. They don't respond to medicine. But he also acknowledged that in the United States, it's much cheaper to have surgery, and I bet the insurance companies are going to make people have surgery rather than starting on medications. There is a study published recently which was quoted by Aaron, that this was from Morgan Stanley, that the anti-obesity medication market is going to increase almost 15-fold in next 5 years, and almost 9% of population of America will be taking GLP-1s in by year 2035. So your market is anyway bigger than us. Although drugs are available to treat obesity, none of them are curative. This was said by our Francisco Rubino, because when we stop these medications, we gain the weight, and most of time it is the fat which will come back, not the muscles, because every anti-medicus GLP-1s will have muscle loss with the fat loss, and we don't have any control on this. And when they regain weight, it is the fat which will come, and that will worsen the condition of metabolic condition of the person. In fact, treating diabetes will also be very difficult in such situations. More interestingly, he said the efficacy of drug is measured in weeks. What I could see in Rucha's talk was the highest duration was 104 weeks, and we talk about years. Bariatric surgery was observed and measured in years, 10 to 20 years. So just imagine, we have not even passed 20 years of GLP-1. There was only 10 years. I think Liraglutide was introduced in 2014, and now we are in 24. So almost 10 years, and nothing has changed even after the GLP-1. So if we talk about neuromedicines and GLP-1s, these pharmacotherapies are available in more than 6 decades, and only till now only 6 drugs are FDA approved for weight loss, and of which only one is a device which act as a medication, and 2 of them are short term and 4 are long term use. These are the medications. I don't have to take in more details. If you talk about Saxenda, which was approved in 2014, which was GLP-1 analog, the weight loss was 8% in obesity and pre-diabetic group versus 6% those who are diabetic group. Means diabetic persons will lose less weight compared to the non-diabetic group. Similarly, Wegovy, which was introduced recently in different strength, having weight loss about 5 to 16%. And these are different trials on this, and the longest duration of these trials is 68 weeks of double-blind study, wherein the more than 5% weight loss achieved on 81%. 5%, they're talking about 5%. We talk about more than 50%. In 81% semaglutide group versus 31% in placebo group. And this is a placebo versus semaglutide. And if you look at this slide, you just imagine the more than 5% weight loss is achieved in 92%. But if you look at the percentage, if 10% weight loss is achieved in 72, but if you go further down up, so it is 20% weight loss can be achieved only in 34 point, almost 1/3 population, in spite of they continuing these medication for a longer period of time. And this is a comparison of different doses of sema and to 1.1 and 2.4. You can just imagine the weight loss is about 16 to 18 kg in 2.4 milligram versus and this is another step 3 trial on the same. And this is a very important trial wherein they continued semaglutide, and those the one group who discontinued, they regained weight, and those who continued, they continued, but again the weight loss is again 18%. So just imagine anybody who stopped these medicines, they will have weight regain, and the effect of these medicines will go. These are other drugs which are available in market, and these are evolving medicines which are about to come in the future, which will have about 24% weight loss. And this is a tirzepatide, which I talked about. The 72 weeks trial is having 5 mg, 10 and 15 mg. The placebo group has 3.1% versus a 10%, 10 mg drug will have 19% and 15 mg will have 21%. That is what I think Rucha was talking about. But look at the duration, it is 72 weeks only. This is trial Surmount 2, where they have studied this on overweight and people with obesity and diabetes, again 72 weeks. So about 80% people could achieve 5%, and only in placebo it is only 30%. And this is trial 4, Surmount trial 4, which is having 21% weight loss. Although the data is evolving about having promising results, but the study is only 72 weeks. People tend to gain weight once the drug is stopped. This is new drug which is about to come, which is for 3 molecules. But if you look at this study, which is comparing all the drugs, GLP-1s on all other medications available, including diet and lifestyle modification, and you compare the bariatric surgery, it is nowhere even comparable. The difference is so much that none of them are even able to maintain until you continue it for the whole life. the slide which was shown by Rucha is only having 5% weight loss with the semaglutide compared to all other medications. And these are new other drugs which are on a trial. But look at this slide. Muscles are the most important part when you want to treat diabetes or obesity, and we cannot afford to lose muscles because this is a paper published in Lancet wherein the GLP-1 receptor agonist uses leads to short-term weight loss but substantial muscle loss, which decline of muscle mass is much more than age-related muscle loss in this group. And why it is important? Muscles are important because these are the reservoir for amino acids, including those involved in response to stress, trauma, and infection. We need to them for synthesis and storage of glutamine, which is involved in nitrogen transport and immune function. And we need to maintain normal glycemia because the muscles are most important even to maintain normal glycemia because muscles are needed for glucose homeostasis. So sudden loss of skeletal muscle lead to much more worrisome condition. So these are the medications. If you look at medications that started at 1 year, 32% people could continue the medication, and at 2 year, only 15% of people who could continue the medication. And this was published in the New York Times in Washington Post. FDA approved this semaglutide in 2021 for weight loss, and 2023 it was not even continued by the by the insurance companies. Same way, the Trepazide was introduced in 23 and 24. It is not available for weight loss or diabetes management by the insurance companies. If you look at the weight loss, medicines lead to 20 to 25%, and surgery leads to more than 30-35% for the long term. And here it is short term. Diabetes remission, to achieve a HbA1c of 2.2% lower is rare in medical group versus surgical group, wherein 60 to 70% people can achieve HbA1c lower in all the patients. So these are the other side effects which we can talk about. There is significant benefit on the mortality if you look at the metabolic surgery versus other modifications. And look at this this bar. The 2014 they introduced the GLP-1. The number has always increased and they are not reduced in bariatric surgery. And we need to understand that these medicines need to be taken for the whole life, and nobody can afford these medicine for the whole life. So with this, I conclude my talk that GLP-1 drugs are transforming obesity treatment, but they will never replace bariatric or metabolic surgery. The surgery remains the gold standard for severe obesity and those who are having metabolic complications. GLP-1 drugs are effective in preoperative and postoperative care of these patients, and integrated care models are required wherein we can combine surgery and pharmacotherapy together. And future research is required wherein we can study the efficacy of these patients in select group of patients. So if for cancer we are ready to accept surgery with chemotherapy, with radiotherapy, with maintenance dose and everything, and target therapy, but why can't we think the same for obesity or diabetes? So I think, so to conclude, this is my last slide. As I said, that it cannot replace, GLP-1 cannot replace bariatric surgery.
Okay. Okay.